Welcome to this lecture on cancer genes. Here we will be dealing about the most common cancer genes and the cancer that it causes. What if one tiny gene could change the fate of the entire digestive system? That's the power of the APC gene, which is coded in the chromosome 5. It is an autosomal dominant mutation which causes familial adenomatous polyposis. It will present with hundreds to thousands of polyps on colonoscopy with 100% cancer risk. When this APC, familial adenomatous polyposis condition, is associated with a soft tissue or a bone tumor, it forms the Gardner syndrome. When it is associated with the CNS tumors, it forms the Turcot syndrome. Since this has 100% cancer risk, total proctocolectomy at the age of 18 is the treatment if they are suffering from a familial adenomatous polyposis. BCL-2, it is the anti-apoptotic guardian. What does this mean? Normally, the damaged cells die, but when BCL-2 goes rogue, they refuse to, therefore setting the stage for cancer. The translocation 1418 in follicular carcinoma is because results in the translocation 1418 results in BCL-2 gene mutation resulting in follicular carcinoma. Because the BCL-2 will code for anti-apoptotic molecule preventing the programmed cell death. How will the presentation be? Waxing and a waning painless lateral neck mass over 1 to 2 years in adults. So this is a most common indolent non-Hodgkin's lymphoma. So you need to know that BCL-2 overexpression will increase this lifespan because of blocked apoptosis. BCR-ABL gene fusion. What happens when two genes fuse and create a relentless cancer driving engine? That's the story of BCR-ABL in chronic myeloid leukemia. The BCR-ABL fusion will result in a translocation of 922, thereby creating the Philadelphia chromosome. This fusion protein is present in the Philadelphia chromosome, or the Philadelphia chromosome is what it is called when they two fuse. So it codes for an oncogenic tyrosine kinase which will drive the chronic myelogenous leukemia. Because what is the basis for chronic myelogenous leukemia? There is abundant myelocytes, promyelocytes as well as metamyelocytes. They are all in a premature stage and not in a mature neutrophil form. Therefore, the leukocyte alkaline phosphatase will be low. Only the leukocyte alkaline phosphatase present in the mature cells will be high. Only if the cells are mature, the alkaline phosphatase will be high. Here, it is mostly the precursor cells. Therefore, the alkaline phosphatase is low. So, how is the presentation? They will be presenting with, since there are all type of cells, they will be presenting with classic soup appearance. So, it is called as the motley mix. That is a classic soup with all different types of vegetables, right? So, that is the way the CML will present. The treatment is, it is treated with imatinib, which targets the BCR-ABL tyrosine kinase specifically. So, thereby blocking the oncogenic signaling. But it has a side effect. It will result in fluid retention as well as in peripheral edema. Let's see about BRAF. BRAF, BRAF isn't just a gene. It is the accelerator pedal for melanoma growth. So it is a proto-oncogene which is commonly matured in melanomas. It will code for serine 309 kinase in this melanoma pathway. Therefore, it is crucial for melanoma pathogenesis and targeted therapy development. What about the BRCA 1 or 2? The faulty BRCA gene doesn't cause breast cancer instantly, but it silently increases the risk over a lifetime. This is a tumor suppressor gene for recombinational double-stranded DNA repair. What do I mean? When there is a DNA repair, then it has to be repaired. That is, when there is a DNA damage, it has to be repaired. That repair gene is being suppressed. So that is because of the BRCA 1 or 2. It increases the risk of breast or gynecological cancers in females and breast or testicular cancers in males. What is the treatment? Bilateral oophorectomy with mastectomy is the treatment if BRCA gene is confirmed. CKIT. The CKIT will give rise to gastrointestinal stromal tumors. What if one tiny mutation could make the gut cells grow uncontrollably? That's the story of CKIT in gastrointestinal stromal tumors. The CKIT is a proto-oncogene which is mutated in GIST. The GIST, that is a gastrointestinal stromal tumor, is the most common mesenchymal tumor of the GIT. What about CMYC? The CMYC leads to the translocation of 814, leading to a non-Hodgkin subtype, that is a Burkitt's lymphoma. This will present with a jaw or abdominal mass in children or an young adult, as it codes for the transcription factor driving the cell proliferation. What about EGFR? EGFR is the growth signal, coding for non-small cell lung cancer such as adenocarcinoma as well as glioblastoma multiforme, because this gene codes for EGFR tyrosine kinase driving uncontrolled growth signals. The erlotinib is the treatment which targets EGFR tyrosine kinase pathway. Let's see about the HER2/neu. The HER2/neu receptor is overexpressed in aggressive breast cancer. So when there is a HER2 positive status, then it means it is a poor prognostic factor, because this will lead on to tyrosine kinase being overexpressed in aggressive breast cancers. But the good news is we have a treatment, that is the trastuzumab or the Herceptin, which targets the HER2/neu receptors and therefore treat the breast cancer. But the caveat here is the HER2/neu receptor is also present on the cardiac myocytes. Therefore, trastuzumab can cause cardiotoxicity. JAK2. This is the myeloproliferative master. JAK2 can cause high RBCs, high WBCs platelets, increased basophils, increased platelets. So, in short, it causes polycythemia vera, it increases all the cell lines, and it also causes myelofibrosis. Myelofibrosis is fibrosis of the bone marrow. So, the doubt over here is when there is a hyperactive JAK2 and it is deriving the excess production of blood cells, then why should it also cause myelofibrosis? Because they both are at the two different ends, isn't it, of the disease presentation. This is because over the years of uncontrolled proliferation, the bone marrow becomes stressed. The hyperactive cells release the cytokines like transforming growth factor beta, PDGF, etc. These cytokines will stimulate the fibroblasts, resulting in the deposition of collagen, leading to myelofibrosis. In other words, myelofibrosis is the late consequence of prolonged overproduction. So, in short, it presents JAK2 mutation presents with polycythemia vera, thrombocytosis as well as myelofibrosis. This is the crux. Now, it increases all the cell lines. That is the crux. Now, if you see, why do they also present with pruritus? This is because of the increased basophil. After showers, they have a pruritus. This is the additional features. How does the erythropoietin be? Already because of the JAK2 mutation, there is high RBCs. Therefore, the erythropoietin is low because of the negative feedback. How about what is the result of the increased platelets? Increased platelets can result in hyperviscosity-like syndrome. Thereby, not only increased platelets, because it has all other cell lines are also increased. Therefore, they can present with hyperviscosity-like syndrome, resulting in finger pain and discoloration. How about the myelofibrosis will present? The bone marrow is fibrosed. Therefore, there will be a dry tap. So once the bone marrow is tapped, we are not going to aspirate anything. Secondly, they can present with defective hematopoiesis. Thirdly, they can present with teardrop RBCs. What does it mean? When the RBCs are compressed and push themselves out of the bone marrow, In a fibrosed part, from the fibrosed, see, it has to, the RBC has to push itself through the fibrosed area and come out. So when it is pushing itself through the fibrosed area, the shape alters, resulting in dry tap. So these altered cells, these defective cells, are taken up by the spleen and destroyed. Therefore, they present with massive splenomegaly. What about the KRAS? The KRAS is the colon cancer initiator. How? So first, KRAS is a proto-oncogene. So hence, first gene that is mutated. Then the P10 is mutated, DCC is mutated, and TP53 is mutated. So the final gene that is mutated is TP53. So all this can result in a colon cancer. What about the MEN1 syndrome? The MEN1 can cause pituitary, parathyroid, and pancreatic. In pituitary, it can result in prolactinoma. In parathyroid, it can result in parathyroid adenoma or hyperplasia. In pancreatic, it can result in gastronoma. So either of the findings can be given alone, and the answer can be MEN1, which is responsible for MEN gene, which is responsible for MEN1 disease. So with this, we have come to the end of the part 1 of the cancer genes. If you have made it this far, all the best for your exams. You will do very well. I have mentoring lessons. I am taking mentoring lessons for medical graduates and USMLE aspirants. If you like to get mentored by me, send me a message in the comments. I am Dr. Veena with a passion for teaching. All the best. Have a good day.